Welcome, everyone. This is Dr. Jenny Hobson and Dr.
Cortez. Hi.
We're here to interview a dear friend and colleague, Cynthia Stein, physical therapist. Cynthia, thank you so much for joining us.
Thank you for inviting me.
You're welcome.
I was just at Cindy's course, online program. It was so exciting. So I cannot wait for this interview. So let's start it.
Okay.
Thanks,
I'm going to
Martha.
just briefly say a little bit about who Cynthia is. Cynthia Stein graduated from the University of Pittsburgh with a BS in physical therapy and from Temple University with a master's in education. She served as a commissioned officer in the U.S. Navy as a staff physical therapist at Annapolis Naval Hospital, and then served as a chief physical therapist at the Philadelphia Naval Hospital. She owned and operated Squirrel Hill Physical Therapy for 30 years in Pittsburgh, Pennsylvania. During this time, she attended extensive training on methods for treating concussion. This included standard vestibular rehab and alternative methods. She has been teaching nasal release technique for healthcare practitioners around the world for 3 years. You can visit her website at conquerconcussion.com for more information. Welcome, Cynthia. Thank you so much for being here. We are thrilled to have you.
Thank you, Jen. Actually, I've been teaching longer than 3 years. It's been more like
that.
8 years.
8 years.
That's an old bio.
That's right. That's right.
Yes. I was going too much experience. That doesn't, no, this is an exceptionally experience. It's beyond PT because the course, I was like, okay, so we're going to talk about it, but then went on to like, most people don't bring up the vestibular. Most people don't examine the eye on the tracking to see where the strain is in order to address the nose. You know, that's going to that whole world of rhinometry where it's not just the nasal, it's the posture. It's not just the posture. You got to look up. It's the eyes. So it's all connected. And then she went on to the lymphatics, the fascial releases. So I was like, oh my God, this is unbelievable. So I really appreciate your course, but let's get on to understand, well, what is nasal release?
Yes.
Why is it involved with trauma? You know, like you talked about the blast wave. I couldn't believe that one.
Yeah, nasal release technique is a chiropractic technique. I discovered it when I was taking a class out west. It was originally taught at Western States Chiropractic College by a guy by the name of J.R. Stober. He really was the person that put it together and really made it doable. And so I learned it from a chiropractor that was trained at Western States, and that was about 10 years ago. So I've been doing this procedure for 10 years. Essentially, it uses a mechanical device called a blood pressure bulb with a finger cot attached to it. You insert it in between the turbinates of the nose, you inflate it, and miraculously, it moves the bones of the skull. And it really does a whole lot for the 3 things that it does a whole lot for are sinus problems, post-concussion syndrome, and headaches. There's a lot of other things it helps too, but those are the primary things that are amazingly helped.
Yeah, I was looking at the list and going headaches, dizziness, vertigo, fatigue, sleep disturbance, irritability, visual disturbances, depression. I'm going, wait a minute, that's also coincides with TMD and
TMD and
then
sleep
cervical compression of occiput and C1. I'm like, and now we're addressing it in the nasal. And you showed us through the inferior turbinates, then the middle turbinates, and then the superior area, because there's different entrances and angling that you have to understand. But I'm still shocked with the concussion. Can you tell us more about that?
Well, I mean, there's different kinds of concussions, and there are phenotypes to concussion that cause different kinds of symptoms. There's an ocular motor concussion that people can have problems with eye tracking, but then people also have ones where they have cognitive problems. They have concussions that cause anxiety and depression. So concussion can be caused not only by hitting your head, but it can also be caused by blast wave injury. And that's what is happening to our military guys, is they're messing up their brains by blast wave injuries. The treatment for that is a little bit different than treating a football player. You've got to really address their problem early on, because this blast wave injury, acoustic wave coming into the head at the speed of sound, causes diffuse damage of the brain. And if we don't help that early on, they form a major inflammatory response in the brain, which leads to a lot of damage.
Can we
But
go
it's the
back a little bit
blast-
though?
Yeah,
Go
go ahead.
ahead.
What
No,
is
it's
the
just like,
release, right?
I'm sorry?
You go back to basics.
we need to kind of go back because we got, an audience that's listening. We both, Martha and I took your class 7 years ago, and it's really transformed the way I treat concussion patients. And me and Cindy and I have been kind of collaborating, and I will call her with problems. Not sure if I can do the nasal release with certain people that have nasal surgeries, and we'll just go back and forth. And she's been wonderful, really supporting me while I learned this about 7 years ago. But let's, for the sake of the audience, I just want to go back and have people quite just understand the nasal release technique. It's in the world of like osteopathic manual medicine, right? It's like
Yes.
there's the bones of the skull
And chiropractics.
and chiropractic, of course. But the bones of the skull should move. They should move as we are living beings.
Subtly move.
Subtly.
And they should have
expand
respiratory
and
and
contract, right?
expiration and contracting and yes, and expand.
The only people that don't move are people that are
Dead.
deceased. They're dead.
Yes,
Their
that's
heads are
right.
stiff, right?
Right.
Yes.
There
So-
are collagen fibers, there's vascularizations to the sutures, and there's fluid movement.
So in that case, can you, the way I explain it to people, and tell me if I'm wrong, is that, when you feel this with patients going to do it for the first time, they're really a little anxious, and they have all these symptoms that you mentioned. But the way I explain it is that you put the finger cot in, and it will expand in the nasal cavity, allowing any area that absorbed that blow to the head, if it's concussion, and it will push against those bones where they absorbed it and maybe stiffened the skull. Is that correct?
Yes, and the different insertions, and I can show you that right now. I do a lower insertion, which is along the floor of the nose. That one gets the maxillary and palatine suture, which is on the roof of the mouth. And then obviously we know that the maxilla and the palatine articulate with a bunch of bones. So we indirectly move the bones that it articulates with. The second insertion is done at a 45-degree angle like that on both sides. That gets the zygoma sutures, which is the cheekbone here. And then the zygoma out of the only articulates with 4 bones, but it indirectly moves those bones when you do the second insertion. The third insertion is the one that gets a bone that nobody has ever, generationally or themselves, it's never been moved. So a lot of stuff stays up into this jamming of this bone. That is the sphenoid, which looks like a butterfly, and it's where the pituitary sits. And it's the cornerstone bone of the eyeball, which is yellow in here, and it has 5 of the 6 extraocular muscles attaching to it. The eyeball to the apex of the sphenoid. The maxilla has 1 extraocular muscle attaching to it. So this bone is, when we do this insertion, you go up as far as you can and then up above the second turbinate with it. And that gets the sutures of the sphenoid, which is very circuitous, moving. And I'll tell you what, amazing things happen after you do the sphenoid, because you're changing the way that person's eyes track. And I've also seen hormonal changes from it. It's just truly an amazing procedure. So
the balloon, when it goes in and it expands, you want it to go down to the throat, correct?
Yes, yes,
So it's going to travel from the nasal cavity as you pump 2 or 3 or 4 times, and either with 1 or more finger cuts, depending on what you want.
right.
You want it to travel down. If it doesn't travel down, what does that mean?
It means that you haven't really pushed the palatine bone down. J.R. Stober actually said that the palatine was the brake. And that's part of the reason why the suck reflex has to be so good after birth, because that when a baby sucks very strongly, it helps for the repositioning the palatine bone.
So if that's the case, you continue doing it with more pressure or more pumps
Yes.
until it goes down.
You never
Right.
back off on pumps or pressure. You always add more. And then once it does go down the throat in all the positions, which there are 8 positions, lower, middle, upper, and then back down to the lower position. Once you do that, you have to add another balloon on, but you never back down on the inflations. You add another inflation every time the person comes in to see you.
Wonderful. And so, you know, people ask me, well, how long does it take? How many sessions? You know, and I can't ever say, I say definitively, because everybody's different. Everybody has a different concussion, a different injury. What do you normally tell people?
It takes 5 minutes to do the procedure. And I usually get people better by 5 treatments. It's pretty amazing. And that all came about when my work has evolved from the time when I started doing it. I've added more things from my understanding. Like I now have an exam that determines eye restriction. And then I look at how the neck affects the eye restriction and how the jaw affects the eye restriction. So the patient can see when I examine them that, oh, wow, I have a hard time taking my eye up there. And then after the treatment, they can do it. The restriction goes away. So
therefore, if they have, you know, the way I say it, and Martha, you can correct me too. If they are standing against a wall and you're testing their eyes and you have them follow your finger up and down, right and left, and the diagonal up and down,
and
right,
the head
you know,
has to stay still.
And I say, well, if you feel eye strain or eye pain, let's pick the one that's the most. Is that right?
Yes.
So
So for example, I take them through the extraocular movements, which are up, down, right, left, diagonals, and then convergence. And I find usually in concussed people, they'll have more than one restricted movement, but they'll have one dominant one. I take the dominant restriction. I then look at the dominant restriction. Let's say, for example, Jen and Martha, it's looking up with your eyes. I then tell them to go through the neck movements, extend your head and look up with your eyes. Does that increase the restriction in the eye? And they say yes or no. Then I do flexion, I do rotation and side bending. So once I've found the dominant neck position, I then have the person, let's say, for example, the dominant neck position was left rotation with eyes up. I then look at it in relation to the jaw. I have them open their mouth up as wide as they can, seeing if that increases the restriction. And then I have them, if it doesn't, then I have them clench and see if clenching increases the restriction.
So it's not only eyes, it's
after the procedure, I see if the restrictions are cleared up, and they usually are. You saw it, Martha, in the class.
Yes.
Everybody's restriction cleared up in the class. Not a couple, not completely, but a couple completely.
But it made a difference. So it's really interesting because when I do TMJ or I do a tongue release, if I'm doing a fascial tongue release, whether you're frenectomy or frenuloplasty, especially frenuloplasty, I'm looking to increase the range of motion from the neck, but doing complete frenuloplasty and reduction and even muscle thinness. And so it was so interesting for it was just opening up here. It's not surgical. It's creating a space, because I imagine it was stiff and even the collagen fibers were stiff.
That's
and
right.
You're giving it a movement.
You have to understand that 80% of all the people that go through vestibular treatment with physical therapy after a concussion get better. Why they get better is because one of the treatments in vestibular management is eye strengthening exercises. If the eyes can be strengthened, it tends to help pull the muscles back into place. 20% of the people that are concussed do not get better with that. And they're the ones that end up floundering, looking for other treatments. That's part of the reason why I discovered this thing. I would do cranial work and lymph work on my patients that would come to me with their post-concussion symptoms, as well as the vestibular things. And we still weren't getting everybody better. So when I discovered this procedure, I found a gold mine of something that really is amazing for that 20% that don't get better.
It's been remarkable in my practice. And, you know, I do cranial work too. I work with a really great therapist that was certified through the Michigan State Osteopathic School. So she really would understand if the sphenoid was externally or internally rotated and stuck in one position, and if that wasn't expanding there. And we would co-treat, and I'd say, okay, feel the head. Let me do your analysis, your diagnosis of normally the sphenoid bone is out of place or not moving well in one quadrant. And then we would do the release and it would make a huge difference. She's like, oh my goodness. So I knew that, you know, I think the combination of those two things with lymphatic drainage and vestibular therapy is just groundbreaking for this population. Now, let's talk about the research. There's not a lot of research.
There's one article that was written by a group of chiropractors that was done for sinus problems. There's been nothing done for concussion.
So let's tell the public about the research project that we're working on right now.
This fell into my hands because I discovered this device through a Dr. Deborah Zielinski called Right Eye. Right Eye is a computerized system that has the ability to for a patient to sit in front of their this computer screen. It hones in on the eye with a laser or whatever. I'm not sure exactly how the technology works, but you then have the patient move their eyes in the extraocular movements, which are up, down, right, left, diagonals, and convergence, and you can actually see a graph
yeah,
of the way their eye tracking is, and it'll be skewed. There'll be blips in it. So it's a fabulous way of seeing the before and after effects of nasal release technique. So what we're doing is that we're also we discovered that many of these people that have had concussions also have breathing issues. They have obstructive breathing issues, and so what we're doing is that we're using a rhinomanometer in this study too. And so we're going to test airflow in the nostril. So we are going to pre-test with Bright Eye, pre-test with the rhinomanometer. We're then going to do a very good treatment of nasal release technique in all 8 positions, inflating it until the balloon goes into the nasopharynx. And then after the treatment, we are going to retest them with both devices to see, number one, if Right Eye is showing that is changing, eye tracking has changed, and then also with the rhinomanometer to see if the airway has opened up. And I know for sure that the rhinomanometer is going to show that there's more airflow. I'm praying and hoping, and I actually probably think it will show too, that the eye tracking changes.
Yeah,
because we're putting the bones where the eye muscles attach back into the right position.
Yeah, and the Right Eye is research grade equipment. This is very expensive equipment that will allow us to really write up a good statistical analysis of the results. So we're really hoping that this wonderful technique does what we think it does, because it's gotten so many of our patients better. But the eye tracking and the nasal flow, you know, Martha and I are all about the nose and breathing through the nose. And I know that these concussion patients are all breathing patients, because if you have a bad concussion, and this is what I learned from one of my mentors, Patrick McEwen, if you are in a state of trauma for more than 24 hours, your breathing changes to that rate and that pattern.
Wow, that's interesting.
So if you are in a bad way because of a concussion, you end up rapidly breathing, sometimes changing to either chest or mouth breathing. And if it stays for longer than 24 hours, it's part of you. It's like how your body adapts, your brain adapts, until you meet someone like us that can change that and really give you awareness of nose breathing, slow breathing, and that you are over breathing or hyperventilating. So this study is going to be huge. And
I think it's going to be a game changer. I think we will succeed because of to the two of you with your powerhouses. We will succeed in getting this into the standard of care.
Yeah. And there's so many people suffering right now. So
they kill themselves over it. What got me really interested in this, being ex-military, I live right across the street from the military cemetery. When I see all these young guys dead over there, I get emotional. So my goal is really to help the military guys with this. We need to keep 35% of all the people on the that are homeless are military. And the second thing is 21 or 2 military guys kill themselves every day, over PTSD, which, remember, what is the standard of care for PTSD right now? Medication and psychotherapy. They think it's an emotional problem. It's not. It is a morphologic problem in the brain caused by injury to the brain.
Let's talk about that.
Wave or hitting your head.
So explain to everybody, like, when you get a concussion, what happens to the brain? Like, there is it's almost like a whiplash within the cavity of the skull.
It's called a contra-coup injury. So think of it this way. You put a hard-boiled egg in a bottle of water. Benedict Omalu in the movie Concussion showed this. He put a hard-boiled egg in a bottle and he shook it. He said, when you hit your body or you hit your head, or you're in a car accident, this is what happens to the brain. It bumps up against the rigid skull. And as a result of that, we get bleeding, we get micro tears, we get blast wave is even worse because it goes in and it damages the neural connections in the white and gray matter. After the brain wants to stabilize itself after the concussion. And so what it does is just like what happens when you bump your elbow, an inflammatory response happens, which stabilizes the area and helps it to heal. But unfortunately, because in the concussion, we tend to injure our lymphatic vessels, which, by the way, were just discovered in 2015. We have lymphatic vessels in the brain, but they're very delicate. And when we injure those, they do not have the ability to reroute unless someone that is skilled in lymphatic work, like I am, knows how to help that. And that can all be done with lymphatic drainage. And that's why lymph work, and I think also electromagnetic treatment, is very important. That's the first thing that needs to be done after the injury. And obviously the person that's hit their head has to be checked out to make sure there is no fracture and that there's no, like bleeding or dangerous stuff going on. So that's not, unfortunately, people aren't getting early treatment. They tend to come 2 years later.
No, and they also are not, this technique, because it's not mainstream, it's not what the doctors are prescribing, really. They give you vestibular therapy and rest at home in a dark room kind of thing. Am I wrong?
That's right. That's what it is.
So we are really trying to get this technique out so that people are. I've treated a 7-year-old with this technique. I didn't do all 8 insertions, but they had a concussion because of a soccer header, and this is something that can really change the lives of so many young athletes, so many, how many?
Remember, the standard of care, they're not putting their hands on the patient. The PTs are just doing all this exercise unless the person has a cervicogenic concussion,
Right.
their neck's hurting, and then maybe they'll work on the neck a little bit. But
Right.
they're not doing anything to reposition what's been knocked out of whack. And
Yeah.
they're also not doing anything to decrease the inflammation that has come as a result of the concussion. You also have to remember that concussion is cumulative. Every time you hit your head, you're jamming yourself even more. What is the first jam, Jen? The first jam is birth. We
Right.
come from a small space, our head gets munched. And then as a toddler, we hit our head multitudinous times. And then we end up, going and playing sports, and then we really do ourselves in. And these people are, ending up with Alzheimer's and dementia from this. It's called CTE, chronic traumatic encephalopathy. Their brains shrink and they get huge holes in their brain, and it doesn't work very well anymore. Almost every NFL football player that has been examined by Ann McKee's brain bank, and there's a few other brain banks, Mayo has one, all of them, almost all of them have CTE. I'm talking like only a few don't.
Right. Right.
That's how it was discovered. Bennett Omalu saw it in an ex-Steeler by the name of Mike Webster, who everybody in Pittsburgh, I used to live in Pittsburgh before I moved to Annapolis. Everybody thought he was crazy. He wasn't crazy. He was brain damaged from playing football. They said that he was hit in the head so many times, it was like being in 25,000 car accidents.
Oh my goodness.
Tragic. He died of a heart attack when he was 50 years old. He didn't kill himself. He died of a heart attack.
Now,
A lot of guys have killed, a lot of football players have killed themselves over this.
I've been reached out by a patient, and this was a couple years ago, that they wanted their infant to have it done. Have you heard of anybody doing that type of work?
J.R. Stober, the originator of the technique, was known for doing infants. And that makes a whole lot of sense because you're correcting the cranial dysfunction after birth.
Right.
You have to remember, cranial dysfunction is, you not only inherit your cranial makeup, the way your bones are put together, but you also they get messed up in birth. And so you get a baby and you correct all that. That baby probably won't have a short leg then, or a high pelvis, or a T, they'll be in better alignment in their life. A baby is malleable. You can put bones back into position and really help them.
I didn't end up doing it, but I called a few chiropractors that had a history of doing that technique to a baby. Have you done any infants?
The youngest I've done was 6 or 7. I never got babies in my practice.
Okay. Could you tell everybody listening, what are the precautions that you don't want to do it if you have certain things? Let's talk about that.
You don't want to do somebody that has a bleeding disorder, because every so often you have nosebleeds from this, and you don't want to have to send them to the hospital. So you don't want to do a hemophiliac, or even somebody that's on a whole lot of blood thinners, although I think that would tend to clot and end, but in hemophilia, it could be very dangerous. You also want to take caution with people that have had a lot of surgery to their face and nose. That does not contraindicate the procedure. What you do with that is you just start gently and you ease the person into it. And then the other thing you want to be careful with is asthma. I've never seen an asthma attack after I've done the procedure, but I guess it probably could happen. So you want to make sure they have their inhaler. The other thing is you want to make sure your patient is also psychiatrically able to be able to take the procedure. So if you get a gut feeling that that for some reason you shouldn't be doing it on them, you should listen to that.
Yeah, I just performed it on someone that had a hyperactive gag reflex, Martha.
Oh, yeah.
the cranial nervous system's a little off, and it went down the nose and it got caught. Let's explain that, because that's a
Yeah, yeah.
scary feeling when maybe you have a Mallampati 4 where your airway's compromised, it's low, your soft palate's low in the back of your throat, and you put the balloon goes down to the throat, and then it gets stuck. You press the button to disengage and it gets stuck. Explain that and what you
I
do.
can tell that through a patient that I had a professional soccer player came to me that was part of the 20% that didn't get better with the standard of care. He came in from Columbus, Ohio to see me in Pittsburgh. I did him for 2 days and I couldn't get it to go down the throat, and I couldn't figure out why. The person that taught me why was a neuromuscular dentist that I know, Alexander George. And she said, he has an overactive gag reflex. You're never going to get it to go down the throat. What happens is the gag kicks in and it pushes the balloon back out. So he had to leave the treatment, and he was so disappointed. But the story ends in a good way. He moved to California. He saw a colleague of mine named Adam Del Torto. Adam did the procedure, and he did it. He must have inflated it so fast that this kid's gag didn't kick in. What happened is the balloon went down, it manipulated the bones, but it got stuck because the gag kicked in. So Adam had to go into the mouth and break it in the mouth. The person's not going to smother when that happens, but it is a little disconcerting.
Yeah, and that happens probably to maybe 10% of my patients that I do it to, and I always warn them, don't worry. The balloon's going to feel like it's choking you in the throat. I will pop it if it doesn't come out naturally. Right. And, if it doesn't come out on its own, so don't panic. So it's really teaching those few things that may happen. And then it's a little bit of a pain in the butt because you got to redo. There was one time I had to redo it 8 times because he was convinced he wanted the procedure. He didn't care that it kept getting stuck. He was getting the release, but sometimes it's the airway. Sometimes it's just like it's too compromised.
That's right.
And sometimes I will squeeze it to stretch the airway and to open up the airway and hold it a little bit longer while I'm in there.
It's actually a good thing that it goes down in somebody that has a compromised airway, because you are stretching the soft tissue back there and hopefully opening it up a bit.
Yeah. Martha, do you have any last questions for Cynthia? I know you just took the course, so it's maybe tell everybody what the course was like, and if there's any practitioners that want to learn from Cynthia, it's tell them what that was like.
I like that it was online. I didn't have to go anywhere again.
It was online. That's right.
Online. I think that's a wonderful thing. And then Cynthia, as we call her, was actually able, we would do the eye strains, we would stand up and strain. She was able to individually be able to examine what we were doing with the strains. So as a person who's going to do it, learn it, then we were also addressing our strains so that by the end of the session, each of us were actually feeling better. And then she directed it really well so that we didn't have that feeling like, are we going to suffocate ourselves? Because here's you're putting a bulb, first a toothpick, then a bulb, and then you're going in directions that you've never gone in your nose that far. And it wasn't a big deal because Cynthia was actually very calm about it. And she addressed each one of us as we were in the class. And it was actually quite wonderful. It was a really wonderful experience. I loved online. I love that it was directed to each one of us. It wasn't like a full class and we all do it together. It's like, no, each one of us were the strains. And even the one who had the one with the mouth, that had the range of motion, the neck, and then the mouth, TMJ, then the clench. So they had a combination strain, TMJ and neck. That was amazing.
It's powerful to see it correct.
Yes. And I'm going, okay, sleep apnea doesn't breathe well. But look at what you can start with first.
Right. Every child before they have orthodontics or anybody that's going to have maxillofacial surgery should have the procedure done on them just so they have no jamming in the skull. I mean, you stabilize, put a splint in or you put bars in to move the mandible, you're going to fixate the cranial
No,
dysfunction.
automatically.
What is that going to lead to later?
Yeah,
in life?
the osteopaths are really like, we only like the ALF is cranially correct.
Right.
But most appliances do fixate, but then they eventually, if they're doing expanders, then they eventually allow the bone
Expand.
to open up because you're now stretching the sutures. And then C1, C2, then you're going C7, then lumbar 4, and that's.
But my
Yeah.
question, Martha, does it get the sphenoid when you put the expanders in? Probably not. It's probably just
Never.
doing the maxilla and the palatine.
Because it's always been my discussion with our PTs and osteopaths. It's like, well, the sphenoid has that funny side bend right with, because the ear is up and the temporal plate is up and that ear is externally rotated because you see less of it. And I'm going, how are you going to get the sphenoid? That's always been my question. And now the question is like, how are we going to get them to breathe and get the sphenoid?
Yeah.
Well, we got an answer.
How we
Um,
have, and the sphenoid has all the cranial nerves. So if
Absolutely.
it's side bend torsioned, now side bend, now all those nerves have all the symptomology and even numbness. I've had people come in with numbness in the palate.
Yeah.
Doctors, they go, what do? I go, you don't get operations, you don't take medication, and we work on opening up that maxilla. And all I could think of is what else should I be doing for them? Now I'm thinking, ooh, nasal and,
Release.
and yeah,
Now you have another modality.
I like the modality. I am genuinely liking it.
Yes.
Yeah.
So, Cindy, where
Well,
can people, where can people find out how to sign up for your course or information?
Conquerconcussion.com is the name of my website.
Can you say
And
that
there-
again and spell it?
CONQUER, conquer, concussion, CONCUSSION.com. And you go in there and there's a place that you can do a form that fill out and it'll come to me and then I call you or you sign up for the class.
Wonderful. And then, I'm doing this in Chicago, and, around Chicago and Glenview and in Lincoln Park and downtown. Martha, you're going to be doing it in New York City. And I know Brad Gilden does it as well with his staff in New York City. But is there a list of practitioners?
Yes, on my website, the
practitioner?
list of, I have combined the people that I train with other lists, like Adam's list, other people that have trained people in it. So yes, I have a pretty extensive list of people that do it on my website.
Wonderful. Well, so if anybody's interested, please go visit conquerconcussion.com. Cindy, is there any
I
last?
just want to say, I always provide support. That's part of, if you take my class, I'm always there for you to answer questions.
I always ask our interviewees, if there's one thing to stay healthy, from your experience in life, what is the one thing that you can tell the public? How can you best be healthy and stay healthy in your life?
Well, I think breathing is very important and good nutrition and exercise.
And exercise, right?
Right. You got it.
And also being happy,
Yeah.
trying to do things that make you happy.
Yeah. Thank you for that. Thank you for that. And we would love to have you again sometime, Cindy.
I'd love to. I think it would be great to do this again after we do our case study.
Yeah, let's
So
do
we
it.
can report what we've come up with.
I like that. That is excellent.
Wonderful. Okay. Well, thank you so much for your
Thank you,
time.
Martha and Jen.
Thank you.
Love you.
Thank you so much.
Love
Take
you
care.
too. Take care.